Hi, everyone. Divergence Neuro is so excited to welcome you to the first in our new monthly clinical webinar series called NeuroVerge. I want to introduce the team from Divergence here today. We have Alex Nee, our CEO, with Jeremy Stairs, who's one of our developers, Jeff Moore, our COO, and I am the Director of Customer Success at Divergence Neuro. To lead our webinar, we have Dr. Nathan Brown, our Chief Clinical Advisor. I'm going to turn things over to Dr. Brown to get things started for us.
I kind of think we're in the middle of a revolution in mental health in general and neurofeedback in particular. And there's some things happening with divergence that just kind of represent this, what I'll describe later as a fourth wave in neurofeedback and feedback. So I'm excited to be here and kind of get this series kicked off. Let me just say, for those of you who don't know me yet, let me give you just a couple of points so you know who this guy is that's talking to you. Nathan Brown, I am a clinical psychologist. I've been in practice. Some of you have heard me say since dinosaurs ruled the earth. I was in grad school in the 70s and 80s in Southern California, and I didn't know it at the time, but the first revolution in neurofeedback and biofeedback was well underway in Southern California in those years. That was when, if you read anything about the history of neurofeedback, a lot of those neuroscientists who got neurofeedback and the broader movement of biofeedback going were located in Southern California. I didn't know that. I was in grad school there and mostly went to Southern California because that's where the beach was. But I was fortunate to be able to spend a good bit of time in neurofeedback and biofeedback labs in those days. And I've really done other things over the course of my career, but this has been a through line for me, is this interest in the brain and the body and the connection to all the kind of things that we do as therapists, whether we're psychotherapists or chiropractors or MD across the range. The kind of work that we do begins to have some real roots in the connection between mind and brain and body. And so that's been sort of a fascination for me all the way along. So back in the day, back in the 70s and 80s, you couldn't really do neurofeedback in the clinic. You could do it in the lab, but it was too complicated. You had big giant headsets and so forth. So I packed up all the equipment that I could carry, biofeedback equipment mostly, and went off into clinical practice. And I then witnessed what I would call the second wave of development in this field. And that was in the late 90s, early 2000s, and to get these large tools, devices that could be used in the clinical office. They were expensive, cumbersome, but they allowed us to do neurofeedback in those days. And that was pretty exciting to me. So I bought the cheapest unit they had. You could get units anywhere from $5,000 to $40,000. I went for the $5,000 model and began practicing single channel neurofeedback, kind of picked that up again and kind of integrated it into my clinical practice. In the late 90s, what began to happen at that point, as I've just said, were these the entry into the clinic really wasn't until about 6 or 7 years ago that we began to be able to do remote work. And I would think of that as sort of the third wave. And you have these devices, MindLift and other devices that were back in those days able to begin to allow us to do work at home with clients. And that was pretty revolutionary. I'm here to tell you we're at the brink of a fourth wave. And that is where all of these capabilities are kind of coming together and allowing us with the kind of on the foundation of new technology to do more things than we've been able to do with neuro and biofeedback, and to do what really is my heart's desire, which is to bring this closer to the work that we do every day. So I want to make one point about that before we jump into the meat of the webinar today, and that is to point out that this field has four groups of stakeholders, four groups of people that have a perspective on neurofeedback. One are the tech guys and gals, the coders and the hardware builders and so forth. They have a technical view of these devices, and we are very indebted to them. The coders and the tech people, we wouldn't have this equipment without them. However, they come with a certain perspective that can be really hard for those of us who are in another group, stakeholder group, the clinicians. It can be hard for us to talk. It can be hard for us to know exactly what they mean by some of the technical language. I see a few nods here, so I think you kind of understand what I'm saying. The third group of stakeholders are the neuroscientists, and we're also indebted to them. There is a tremendous amount of research around brain functionality that we have now that is just blows the doors off of what we knew back in the 80s and 90s. But they also speak their own language. If you've ever sat in on a learned neuroscientist, you may find, if you're a clinician, that is a little hard to track what they're saying. It's valuable, it's important, but it's hard to understand how that really meshes with what I do in my clinical practice. Then you got the fourth group, and those are what I call the civilians, the people that we serve, the people that are using these devices. And it's, in my mind, it's incumbent on the therapists to find a way to pull the language and the perspective of the coders and the neuroscientists along with what we know as psychotherapists and find a way to deliver that to the civilians, find a way to deliver that to the patients and clients that we work with. I'm saying all that just to kind of give you an idea that there is a lot of cross-cultural clamor in this field. I said to the head of one platform, you all are building a Ferrari, doing something really amazing with this tool. However, there's a reason Ferrari doesn't have a driver's education, right? Because if you're building a Ferrari, you're going to be thinking about compression ratios and spark plugs and all of that. If we're the driver, we just want to know how to turn it on and how to get from point A to point B. Have any of you ever had that kind of feeling with neuro or biofeedback equipment? It's like, not quite, you got this tool and you have a lot of information, but you're not quite sure how to put it all together. Woman I worked with who was actually working with one of those elaborate models that are available in office, a QEEG system. She said, I feel like I just bought a rocket ship from Elon Musk and I don't know where to put the car keys to turn them on. Well, I didn't have the heart to tell her that, rockets probably don't have ignition keys. I'm not sure how you turn them on, but it's probably some other way than that. As clinicians, I will just say for myself, even with my exposure to neurofeedback, when I'm exposed to a new device, there's a lot to take in. It can be complicated, and we have to kind of translate, if you will. So my reason for pointing this out is, number one, if you feel a little confused or daunted by the technology, or maybe you feel like you have a handle on that, but you're not quite sure you understand the brain neurofunctionality underlying neurofeedback, number one, recognize you have company. This is a lot to absorb, especially when, as a clinician, most of our bandwidth is taken up understanding our own model of psychotherapy and what we're doing with the client. And it can feel like a lot to add this other information on. But what I'm here to tell you, and in my mind, the purpose of this NeuroVerge series is to give you a sense that this is more accessible than you think, that there is more overlap between the realm of psychotherapy and the realm of brain science than maybe you know. There's more immediate application to knowledge of what's happening in your patient's brain than maybe you've been aware. And compared to any time that I've been in practice, this is absolutely the true golden age for beginning to bring neurotherapy tools into the practice and integrate it in a way that as clinicians we can understand and we can see how it fits with the work that we already do. So I'm going to share my screen here and just jump in. And I want to say that you all nod if you can see that, because you're mostly muted. Okay, great. Okay, I'm just going to say that I'm going to go through this at kind of a medium pace. If you have questions, I'm going to reserve time for Q&A at the end. And Lori, I think they can also just pop it into the chat if they have a question. Is that correct?
Yeah, you can just click the chat button, and that's probably a good way to queue things up if you're worried about forgetting your question when we get to that part of the series.
Okay, that's great. Those of you who have done training with me know my expression here: speed me up or slow me down, depending on what your questions are. We'll pick those up at the end. All right, so the title of today's webinar is Raise Your Game. It's a bit of a friendly challenge based on what I was just describing to you. There's never been a better time to integrate these tools into clinical practice. I believe that learning about neurofunctionality at a minimum, better becoming a neurotherapist, will make you a better clinician. If you're at it, maybe you're at an early point in your career and you're just trying to get a handle on everything, neurofeedback will help you with that. Becoming a neurotherapist, understanding brain functionality will help you with this. If you are maybe 10 or 12 years into your practice, maybe you've been quite successful, and I don't know about you, but when I hit that point in my practice, I kind of hit a little bit of a, is that all there is moment? You know, I began to think about other ways I could stretch myself. Neurofeedback, learning neurofeedback and neurotherapy is a very satisfying way of moving through that particular phase in your career. Okay, we are going to see if we can turn the page. Yes, we can. So if you look on the right, this is just kind of a heads up about what's coming in this NeuroVerge webinar series. I want to say, those of you who have seen webinars I've done in other contexts, these are going to be different. We're going to cover some of the same material, but from a very particular perspective. And that perspective is, how do you actually use this stuff in practice? How can knowledge of what a person's latent brain traits are affect the kind of work that you do? That, in my mind, is the thing I want to be able to deliver here and explore with you in these monthly webinars. So you can see some of the various topics that we've got coming up here. Some of them are going to be more clinical, anxiety, depression, so forth. Some of them are going to be very practical. We're going to do a webinar a bit down the road on how to build a neurofeedback practice, how to build one that complements the work you're already doing. And we'll also talk about peak performance a bit downstream. We'll talk about neurofunctional assessment. We will talk about some of the distinctive features of the Divergence system that are coming online just now. And it's really going to be kind of fresh news as we go into that. And we're going to talk about psychotherapy models in the brain. If you're a psychologist, a psychotherapist, anyone who's doing psychotherapy, you have a model, or you have a set of models that likely you have identified that you kind of work with. You want to ask yourself, do I really understand how the brain fits into what it is that I believe promotes change? Every neurotherapy model, every psychotherapy model has a theory of change in it. And if your theory of change doesn't include brain functionality, you're missing something. And that's what we're going to get to in this series. Okay, so for today, we are going to hit 4 main points in about the next half hour, and then we're going to allow time for questions and maybe go a little bit deeper on these topics. First of all, we have people here, I can see by the names that I recognize, who are pretty experienced in neurotherapy, others who are fairly new, and I'm inferring there are some of you who may not even really quite know what neurotherapy or neurofeedback is. So I'm going to split the difference there and give you neurofeedback in 90 seconds. Okay. If you already feel like you know what neurofeedback is, pay attention anyway, because you're welcome to rip me off. You can use my language, use it with your own patients if you find it useful. All right. We're going to talk about kind of a perspective on neurofeedback. The revolution is here. I want to give you some idea of what I mean when I say we're in the 4th wave in this area. And it's, in my mind, having been around this a long time, there's never been a more exciting time to be in practice. Thirdly, we're going to talk about psychotherapy in the brain, give us kind of a systematic framework to think about how brain functionality relates to the way we approach psychotherapy. And finally, become a better therapist and give 3 examples. I'm going to give you 3 examples of how knowledge of an individual's latent traits, which is to say, functional patterns in the brain, affects their behavior, affects their affect, their mood, and how it should affect you as the therapist, because it should actually inform how you work with that person. So I'll give you 3 examples for that, and then we'll have our Q&A, and we'll talk a bit about next steps after this. Okay, on we go. Neurofeedback in 90 seconds. Let the timer start now. Whoops. All right, I'm just gonna hit 5 points. You can see them right there. Point number 1, everybody here probably knows this, the brain's an electrical organ. It's technically an electrochemical organ, right? We have neurochemistry as well as electrical patterns in the brain. Neurofeedback certainly is cognizant of the chemical component, but we're focusing on electrical patterns in the brain that tend to correlate with how an individual functions. Specifically, what we tend to look at in amplitude training, which is the primary form of neurofeedback that Divergence and these other platforms operate in, is we're looking at standard brainwave frequencies and their amplitude. You might think of it as volume. Later, we're going to talk about the metaphor of the brain as a guitar. Amplitude is how loud you strum the guitar, right? Frequency is what you do with the tuning pegs, right? You're changing the frequency of that string. The brain's kind of the same way. We have frequency and amplitude. All right, it turns out that those 2 characteristics affect an individual's functioning. Secondly, the concept of homeostasis and dysregulation. Any of you who've done some study in systems theory understand the idea of homeostasis. The street language for that is balance. The brain seeks balance, okay? The brain has been evolved for hundreds of thousands of years to seek balance, to use information from the environment to seek balance. And that's actually what it does as it goes through life. For instance, if an individual is in a war-torn country, that person's brain is going to learn to be in fight or flight all the time. And you take them out of that country, they are not automatically going to go back to optimal homeostasis, are they? Their brain has learned what we might think of as optimal homeostasis. If you're in a war-torn country, that's to be in fight or flight. But if now you go to a peaceful country, it's suboptimal homeostasis. And literally what has happened is the brain has learned in that context to optimize its state in order to adapt to that context. We often talk about neuroplasticity, which is a concept we'll get to here in a moment. Neuroplasticity works positively. It can also work negatively, you might think. There are brain changes that happen if we live in a war-torn country long enough. The brain tends to respond to it, and over time that affects the functional state. Third concept is operant conditioning. The brain is a learning mechanism. The brain has evolved for 500,000 years or so to optimize information, take information from the environment and use it for optimal functioning. Everything you learned about operant conditioning and the rat in the Skinner box pressing the lever to get the cheese, it's the brain doing it. It's not the rat, it's the rat's brain. And so there is a sense in which neurofeedback is nothing more than operant conditioning with fancy gadgets. We're giving the brain an opportunity to pick up information it likely has lost track of. It has lost its ability to pick up, and we're reestablishing a feedback loop. Okay, that's the concept of a feedback loop. If we have a feedback loop, we are able to have control over physical systems that we are otherwise unable to have control of. Okay. Neuroplasticity is the idea, a fairly profound idea, that when the brain learns a particular brain state and it maintains it long enough, there are triggers in the brain that will start to cause neural, you might think of as repair, there is literal physical change in the brain as it learns to optimize that response. So when we do neurofeedback, we are actually over time triggering neuroplasticity. This is one of the reasons why there's evidence that neurofeedback has a persistent effect. If you do it properly and you give the brain long enough to be in the appropriate state, it will literally change. And that change will allow the brain to persist even when you've finished with the neurofeedback experience. Finally, neurofeedback is an evidence-based practice. This is something that there are certainly practitioners out there that don't really think in these terms, and they just sort of have one tool that they use for everyone. But the fact of the matter is, neurofeedback is something that has quite a strong evidence base to it. I always want to show this book. Those of you who work with me have seen this before. This is called Biofeedback and Neurofeedback. This is the 3rd edition. The 4th edition will be out within a month or two, they tell me. This is basically a compendium of evidence-based of research into the effects of neurofeedback on a whole variety of conditions. So this is a really good starting source if you're looking for that. And Lori, maybe we can put that in the notes on the recording or in the email so folks can have that.
Absolutely.
All right. I'm afraid I went over 90 seconds, didn't I? Okay. Now let's talk about the revolution. The revolution is here, and it's just in time. I don't know if you all noticed, but we've had a pandemic. You all notice that? It has had some fairly massive effects around the world. I have heard, this is unconfirmed, but I've heard from a neuroscientist that theta, which is a brainwave that's involved in the experience of brain fog, that theta is up 3 or 4% worldwide. That's a lot. This is what the brain does when it gets into circumstances that are outside of its control. We get brain fog. And the pandemic has definitely had an effect on our well-being. I'll talk more about that in a moment, but I want to mention the revolution, and it's just in time because we are in this mental health crisis, which we'll discuss. But we're at a moment where we're seeing the advent of what I would generally call electroceuticals. What do I mean by that? I mean biofeedback devices, neurofeedback devices, stimulation devices. There are devices like Alpha Stim and so forth that are providing electrical stimulation to the brain, magnetic stimulation. There is a variety of tools that are blossoming right now. And it's not random. It's because about 10 or 15 years ago, there was a fairly massive influx of funding into brain research. And that is now turning into actual tools that we can use that supplement and extend our reach as therapists. The revolution is here because we now have the potential for flexible remote delivery. Instead of having to have people come into your office, we can send people off to their home to do their neurofeedback training asynchronously, which means you can greatly extend your reach, your effectiveness. If I have to sit with someone for their 20 or 30-minute neurofeedback session, every one of them, it limits my capacity. I am right now currently working with probably 70 people around the world in different contexts because of the flexible remote capabilities that we have now. Fourthly, multiple channels widen your treatment options. One of the things that Divergence is doing that I think is is they're offering remote tools that offer multiple channels. Single channel devices are also very powerful, and this is sort of a matter of your use case. There are some times when one is valuable, sometimes when the other is valuable. You all who have heard me speak before know that my response to the question of which is best is always, it depends. It depends on your use case. But now we have an option that we didn't have before, which is the potential for multiple channels, which means you can start to target not a single area, but a region and have a quicker, more potent effect. The next point, multiple modalities can increase effectiveness. You may have heard the phrase top down, bottom up. This is in reference to the idea of doing neurofeedback, top down, along with biofeedback, bottom up, the body sending down regulating messages to the brain. The potential to begin to integrate neurofeedback and biofeedback is right around the corner. In fact, you can do it right now by using devices separately, but the potential for integrated signal is right there, and that's very exciting. The next point, we're at a point where with neurofeedback, it can become cost-effective for both the clinician and for the client. That's a whole webinar in itself about how to make that work, but just trust me, this is cheaper than a $20,000 system. Let's put it that way. Neurofeedback can enhance most mental health treatment models. If any, let's just talk about psychotherapy for a moment, but I also have in mind everything from chiropractics to naturopathy to physical medicine. All of these models operate because there's something about brain physiology that matches the premises of those particular tools. And to be able to use neurofeedback to allow the brain to reach a desired state can greatly enhance your effectiveness as a therapist, no matter what modality you're using. I'm going to give some examples of that in a moment. Neurofeedback can be used as a standalone treatment. There are times when I describe myself as just the brain mechanic and someone else maybe is doing the psychotherapy, or maybe we're just doing neurotherapy. It can be used standalone. It can also be used in conjunction with psychotherapy and with other methods, and has been in many different ways. Worldwide, the need really truly never has been greater, and I just want to return to that issue of the demand for a moment. This chart is really got my attention a little while ago. This comes from the APA, American Psychological Association. For the last 3-4 years, I think, they've been doing a survey of practitioners, and their timing was impeccable because that was right before the pandemic to the present. And this chart, for instance, shows us the reported increase, the reported demand that therapists have been experiencing since the beginning of the pandemic. You can look at this when you see the recording at your leisure, but I'll just show you the high points or the low points perhaps. And that is anxiety is dramatically up. It up 83% when we were in the height of the pandemic. Even in late 2022, we're at 79% increase over the base rates prior to the pandemic. Okay. Depression, our most recent data, 66%. We've got some abatement on both of those since the pandemic, began to lighten up a little bit. Still, 66% rise in depression since the pandemic. Trauma, stress-related conditions continues to rise. We're at 64%. Okay, sleep conditions. This one, I think, is maybe not quite as high because it already was a problem. We have neurophysiological evidence that human beings do not sleep now nearly as well as they did 40 years ago. There's measurable evidence that we are all bad sleepers compared to how we were in the past, and that has a direct impact on physical and mental conditions. Okay, so I could keep going, but you get the idea, and I think all of us know this, right? All of us are aware, and chances are you're aware in the same way that I am, which is that demand just rose like nothing I'd ever seen during the pandemic. That led to a number of many practitioners burning out and leaving the field. It led to many of us just working harder to try and do everything we could to meet the need. This little sidebar piece of data, that's maybe a little hard for you to read, but this is saying workload changes the perception of practitioners. The percentage of practitioners who feel like they're working harder since the pandemic began. In 2020, it was 31%. We're up to 40% in 2021. It's dropped just a little bit, 38% in 2022. I feel like I've been in that green category, right? And I see nods. I think you all are agreeing with me. This has been an unprecedented time. And I would just say to you, at a certain point, I said to myself what I tell clients, which is if something's not working, you want to think not so much about how to try harder. You want to think about trying different. Don't try harder, try different. That maybe we need to find a different way of approaching our practices. And honestly, I would say for our professions in mental health, we need to find another way to approach mental health. One phrase I sometimes use in my training, and I'm always a little hesitant to do it, but I always get a lot of agreement, is our mental health system in the United States and in other countries that I'm aware of is broken. Anybody agree with that? We are not delivering services in a way that is effective as it could be, and there are all kinds of reasons for that. I'm interested in this one little part of the solution, which is trying different and finding a way to introduce neuro and biofeedback into the work that we do. Okay, so let's turn to that. In the last 15 minutes, I'm going to start to give you some examples here about how what's happening in the brain is relevant to what you do in psychotherapy and as a therapist. So very quickly, I'm going to talk about express traits, latent traits, and the therapeutic process. Express traits, that's what we in the business, in the mental health field, tend to think of as presenting problems. What is it that the patient is saying is their perception of the problem? Okay. Now, there are also times when we may notice something that they're not noticing. So that would also be a presenting problem or an expressed trait. Okay. So the target of most healing is to identify where the pain is, identify where the traits are that we want to change. When you come at it from a psychotherapy perspective, if you're in a traditional model of psychotherapy, you start looking at symptoms and you look at how those symptoms categorize, and pretty soon you end up with a diagnosis, right? You end up with like, this person is depressed, or this person is anxious, or is it an anxious depression? You start looking at kind of combinations like that. It looks very different from the brain perspective. And that brings us to latent traits. Latent traits are the patterns that we see in the brain, specific amplitude and frequency patterns that we see in specific locations of the brain that research has shown tend to produce the express traits that we've been talking about, anxiety, depression, and so forth. And when you look at it from that perspective, a couple of things happen. One is, from a neurotherapy standpoint, you're looking for latent traits that underlie the express traits that the person is complaining of or that you see in their behavior. You don't want to train a latent trait that isn't expressing itself. It's much like in genetics. You can have a genetic propensity for, let's say, diabetes, but the person has done a really good job of diet and exercise, and they have strong genes and all of that. They may either not have diabetes, may never appear for them, or it drops. They're able to drop their blood sugar down. That's because a combination of genetics and risk factors and protective factors are such that person isn't expressing a characteristic that they have an underlying latent trait for, a propensity for. Does that make sense? So in other words, we can have a propensity for depression. We might have too much alpha building up on the front left of the brain. That's one very common pattern that underlies depression. We may see that in the brain, but that person's genetics, risk factors, and protective factors are such that it's not expressing. They're not experiencing depression. So I'm not going to treat depression. I'm not going to treat that latent trait. I'm going to look for another latent trait, if I can, that matches up with the express trait that they're showing. All right. Now, the therapeutic process, as we were just talking about, tends to go from identifying symptoms, looking at how those symptoms fit into clusters and patterns. That leads us to diagnosis. And then let's say we identify this person qualifies for major depression. Okay, so maybe my model is cognitive behavioral therapy. I'm going to base on research that shows that for many people, identifying irrational beliefs and working on the cognitive and behavioral traits that are underlying depression is going to be a way of treating them. Okay, that's a purely psychotherapeutic approach. What if you knew what that person's brain was doing that was leading to that depression or leading to anxiety? Because it may turn out that there are some things about the latent traits that are leading to their particular condition that will affect not only what you could do as a neurotherapist, but actually what you will do as a you will do as a psychotherapist if you're aware of it. Let me give you some examples. First, I want to use my metaphor. I was ambivalent about this slide. It kind of looks like a piece of spam to me, but it's supposed to be a brain guitar. That was as close as I could find on the internet. Here's our metaphor. Think of the brain as a guitar. We are generally in neurofeedback not looking at repairing, we're looking at tuning. Okay, now there are some conditions, TBI, seizures, so forth, where we can have at the very least a mitigating effect on the outfall of those conditions. But in general, neurofeedback is a matter of tuning the guitar. In other words, regaining lost capacity. In neurotherapy, we talk a lot about capacity. Your brain, would appear that you have more capacity than it's currently showing. So let's tune you up and see if you can get to more capacity. That's the role of neurotherapy, is tuning the guitar. The role of psychotherapy is that once you've tuned the guitar, you have to decide what song you're going to play, right? You have choices to make about how you're going to use this instrument that you have now tuned up. So that's a metaphor that I often use with patients to see how these two things go together. Because if you have a really badly tuned guitar, it doesn't matter what kind of song you want to play. It's not going to do a very good job at it. And you can probably think about examples in your caseload that might be like that. Okay, let's talk about becoming a better therapist. I'm going to give you 3 examples here of neurofunctional patterns that affect emotional regulation and should affect the way you approach this particular patient. So these are coming from 3 different real-world patients of mine. I am just going to focus on 1 or 2 of the latent traits, the data that we've gotten from brain neurofunctional assessment. And here's the first one. By the way, I want to give a little shout out to the Divergence folks. This is an advanced screenshot here of the assessment that will be coming out shortly. This is called TheraQ, and I'm going to interpret these here with the arrows here so you can see this. You'll notice over here, we've got the different regions of the brain. We basically, in this assessment, we measure the back part of the brain, posterior at 0.1 in the left. We measure the midbrain here. CZ is basically looking down at the top at the limbic system. And we're looking at F3 and F4. These numbers basically refer to different locations. So F3 is the front left, F4 is the front right. Now, this is a particular client that came to me. Now, remember, probably my default approach in psychotherapy is cognitive behavioral therapy. This was a very frustrating client for me. So those of you who are CBT therapists, maybe you'll be able to identify with this story. This is a person that I worked for quite a while on their ABCs of emotion and identifying maladaptive cognition and that sort of thing. And it just didn't seem to hit anything. They were having trouble actually identifying triggers for maladaptive cognition. They would just tell me, I'm just always anxious. There's never a moment where I don't have this kind of baseline of anxiety. There's an old school term. People don't use it so much anymore, but I think I'm bringing it back. It's called free-floating anxiety. That's anxiety that is basically untethered to events and the cognition surrounding events. You just have this baseline hum of anxiety. And that right there, just observationally, even without reference to neurofeedback, is a clue that you may have amygdala-based anxiety. It's a part of the brain right back here that functions as a primitive alarm. And to make a long story short, sometimes that alarm gets stuck in the on position. And it's like it's like living in an apartment with a smoke detector going off all the time. Okay, you're going to be in a fight or flight state to some degree all the time. Trauma can produce this. There are other things that can produce this that have more to do with the person's history. It will persist even if that person is on an island sipping a Mai Tai. They're still going to have that baseline because that amygdala is sort of stuck in the on position. These kinds of patients can be very frustrating for cognitive behavioral therapists because we think that if we can get them to identify maladaptive cognitions and a few behaviors to change, this should change. It's going to change very slowly, if at all, using that approach, because the problem is not in the front of the brain where you're having those maladaptive cognitions, it's in the back of the brain. So we basically find that from these three statistics. I'm not going to go too far into explaining them, except to say that these are three different ways we look at the back of the brain to determine the brain's capacity to calm that alarm. That basically has to do with the brain's capacity to generate alpha and theta. Those are two slow waves whose function in the back is to calm the alarm down. This was an individual who really didn't begin to turn around because of any CBT work that I did. They began to turn around because I did neurotherapy with them. If I didn't have neurotherapy, and if you're out there thinking, well, I don't have neurotherapy equipment, but I've got a client just like this, do some more somatic kinds of therapies with them. Use progressive relaxation, use relaxation imagery, that kind of thing. Think about this as a deconditioning process that this person, or a counter conditioning process that this person has to undergo, because at some point their amygdala will learn to switch on, and we have to counter condition that. Okay, so free-floating anxiety, this would be one example. If you just listen for that as a clinician and in your intake, try and get a sense of, is there free-floating anxiety, amygdala-based anxiety, or more cortically based anxiety, i.e. anxiety that's driven by thinking? That should be two different strategies, not a one-size-fits-all. Now, sometimes it's both, and that means you have to kind of work on both ends. All right, let's go to 2. This one has to do with the capacity for focus and concentration. I'm giving you an example from each region of the brain. So we have now at CZ, what's happening there is we're looking down at the limbic system. I always carry my brain with me. Many of you have seen this particular brain before. When you put an electrode here at the top of the crown of the head, you're looking right down at the limbic system, which is responsible for managing fight or flight. Okay, so fight or flight, if we're being chased by a bear, a whole bunch of things happen in the body to help keep us safe. A lot of things happen mentally as well. We become functionally ADD if we're being chased by a bear. We're not stopping to concentrate on how great the sunset is. We're scanning, we're looking for a tool, a weapon, a hiding place. Our attention is darting all over the place, right? So that's actually an adaptation if you're being chased by a bear, not an adaptation if you're in high school in a final exam and you can't focus because your alarm has been going off. In this part of the brain, we basically look at two pieces of data. This one is called theta-beta ratio at rest. And this is, theta-beta ratio is just a basic index of dysregulation. Take my word for it at the moment if you don't know that, and I can be happy to explain it to you offline. But what we have here is a yellow zone score on theta-beta ratio at rest. Those of you who have taken my course notice we have yellow zones. Okay. Down here, theta-beta shift. This is telling us what happens when the brain has to shift from being at rest to under demand. And we're flat in the red zone here. So what do these two mean? This one means that we have basic dysregulation at the limbic system, and that's going to affect 5 different functions that the limbic system has. One is the propensity depends on your genetics and your risk and protective factors, but you are at greater risk for a stress-related condition because the limbic system is managing all these messaging out to the body. Attention is at risk, concentration is at risk, emotional regulation is at risk, and interpersonal adaptation is at risk, the way you learn to deal with other people. So if we see a yellow zone score here, this is telling us even in a resting state, there's a certain amount of dysregulation here. And that is that's a fairly serious condition from a neurotherapy standpoint. It means that person really may have one or more of these 5 things going. This was an individual who had some attention problems. They didn't quite qualify for attention deficit, but they had a great deal of interpersonal problems, a lot of anger, a lot of, just being kind of inappropriate kinds of behavior, a lot of impulsivity. A lot of that originates in the limbic system as well. Then we look here and we see that when the person's put under demand, it gets even a little bit worse. Okay. Now, what we're doing in the assessment is asking them to count backwards. It's just sort of a math problem, but it's kind of a proxy for any kind of any kind of demand that's put on the brain. So that could be preparing a project for school. It could be dealing with a difficult emotional situation. That was the case with this person. He was really able to learn a few things about assertion and communication skills, but as soon as he was put under the stress of a demand, as soon as he's actually in front of his office mates, this is where he was having the problem, it all kind of unraveled. He was having trouble here. Okay. These things actually can be trained. We can actually teach the brain to move back into more of a normative state here and help them regain more capacity in these areas. Okay. These are dysregulations that are very, very difficult to change just by psychotherapy. Okay. There are some things you can do at the level of skills, but in terms of what we usually think of as psychotherapy, it's really hard to get at this. Neurotherapy, you can, and then you find that you've got a patient with more capacity, because this directly affects what they're able to get out of your therapy sessions as well. If you're taking them into difficult emotional territory in your therapy sessions, you're putting them under demand. And if you have somebody with a brain that looks like this, they are likely to start to check out. You ever have a patient like that? They have trouble just kind of hanging with you as you're going into some difficult waters with them. It may be not a matter of willpower on their part. It may be that their brain's actually letting them down at this point in the emotional regulation process. Okay, let me give you one other example, and then we're going to take some questions. Now we go to the front. Now, there is a certain emotional regulation process that actually non-neurofeedback professionals have developed. Clinical psychologists and others have developed research around the idea of an emotional regulation sequence, that there's a certain identifiable sequence that we all go through to manage emotions. That sequence starts with being aware I'm having an emotion. If you're not aware you're having an emotion, we call that dissociation, right? That actually often is something that if we see the kind of problem we saw in the previous slide, this kind of dysregulation in the midbrain, it often is underlying a dissociated state. So strengthening this will help them identify, be aware of emotions more. Mindfulness strategies are another way of doing that. Okay. So first you have to be aware you're having an emotion, then you have to identify, well, what's causing it? Where did it come from? And what do I do about it? Those two things have to do with the capacity for divergent thinking. In the front of the head, and by the way, I'm greatly oversimplifying a lot of this to kind of make the point succinctly here today. The front right side of the brain, up in front where we do our actual cognition, does a lot of different things, but you might think of the idea of divergent thinking as being a primary task of the front right part of the brain. Thinking of alternatives, thinking creatively, thinking outside the box. Convergent thinking, that's the province of the front left. That's the capacity to come to conclusion, make decisions, sustain a decision. I'm bringing this one up as an example, a third example for how this can affect your therapy, because this is going to be a person who is in the red zone on the front right. Okay, they're right here. They've got a problem on the front right. That means that that part of the emotional regulation sequence is they are below capacity. They are going to have trouble thinking creatively about why I'm feeling this way and what to do about it. Armed with this information, that helps me tremendously as a therapist, because it means I now know I need to help them with that part. Okay, I need to be breaking it down myself in terms of the emotional regulation sequence. And if I find somebody just coming in and saying, I had this bad thing happen and I just didn't know what to do, armed with this information, you can know this is likely someone who is just simply having trouble identifying what's the emotion connected to, what triggered it, and what do I do about it. And you can model that with them. You can walk through that with them and begin to strengthen that from a therapeutic standpoint. From a neurotherapeutic standpoint, you can train this pattern down into the green zone. You can help them recover capacity. Think of that brain as guitar thing. The brain's not broken. We can actually retune the brain so that it is reliably down here in the normative range. And they then have access to whatever natural capacity they already had to be able to work their way through the emotional regulation sequence. Now, I'll just acknowledge that there's something I've noted here that we will come back to in a later webinar, and that is the emotional regulation process. That's something you may have seen in graduate school. There's a good bit of research around. It's modeled in different ways, but you may have seen that idea of an emotional regulation process. Most of those models for how we manage emotion map really well to the brain. You'd almost think the brain had something to do with it, which, it does. So these are three examples of ways in which you can see a client present at the brain level, how that can affect the way you do your therapy, and potentially how you might treat this if you were doing neurotherapy. All right. I've only gone 8 minutes over, Lori, so we have a little time for a Q&A.
Wonderful. I have one question that I'm actually going to direct you.
There we go.
Yeah, sorry. I'm faster than my computer, which is a terrible thing to be. I have a question that I'm actually going to be directing to Alex, because it's about the future of TheraQ, and maybe an opportunity for Alex to talk a little bit about how it's going to be now versus the future, because it's our newest, not yet released feature. So Alex, the question that has come up is, will TheraQ also have color-coded brain maps?
Yes. So to answer that simply, the answer is yes. We have taken a very phased approach to construct the product of TheraQ, from the very basic neurometrics, the ones that you've just seen Dr. Brown explain in previous part of the presentation, to various more advanced kind of indices that you'll be seeing shortly in a press release of TheraQ 1.0, and ultimately brain maps that will be associated with the raw data that's taken during the assessment. So the answer is yes, we'll be adding that in a more advanced version.
Wonderful. Another question that's come up is, if somebody uses a full cap in the clinic, and I'm going to assume the full cap means the brain bit flex, and they send them home with a headband, will the protocols work on both devices? I can answer that. The answer is maybe, because the BrainBit headband has locked sensor locations. It has 4, you can't change them. The Flex is flexible, hence its name. So as long as the protocols use the same sensor locations, yes. We also see people do something a little bit differently, which is they have some protocols that they use in clinic. So kind of a follow-up or tune-up appointments that they have. And then they have protocols that their patients use at home as kind of their ongoing homework, so to speak.
Yeah. And I would just say, just to underline that, that would be the role of the neurotherapist, would be to do, maybe you do training in clinic that uses all 4 sensors, something like that, but you would then be building a protocol that would match the device that they have at home. And we'll have training to give you a sense of how to do that.
I think there's a lot of curiosity around the devices and how they work and what the differences between them are. And that's great. So there's been a little bit of discussion about it in the open chat. So what I'll do when we send the email out, along with putting in the link to the book that Dr. Brown spoke about, so you can have a look or make a notification for that 4th edition. I'll put these links to the information about our devices and the comparison to them. We also have to include the point that for the forthcoming TheraQ release, the BrainBit Flex is the only device that will work with that. Future devices may be added, but at this time, that's the only device that works.
Okay. Any other questions? Okay. Yeah, go ahead, Laurie.
Thanks, Dr. Brown, for your time. I recognize myself in a lot of what you spoke, because I'm not a clinician, but a patient. So I'm really excited that so many of you turned out for our first NeuroVerge webinar, and we're really hoping to see you again on the 20th. And as we keep going with this, so April 20th will be our next one. We will be posting a link on our website, as well as emailing you a link to the recording with all of those other goodies we spoke about in a few days. If you registered for this, you'll receive a reminder about that and upcoming events. If you don't see it come from us, it could be that somebody shared the invitation with you, which is great, or you're not registered, so you can just sign up. We'd like to hear your feedback about today's webinar. It's our first one. We always want to do better and meet your needs. So you can email us at info@divergenceneuro.com. If Divergence is new to you and you're curious, you can check out our website at www.divergenceneuro.com. And if you want to talk to somebody about how this works and what your practice and can these be partnered together, we'd love to. We'd love to talk to you about that. Again, info@divergenceneuro.com is the best place to reach us. And thanks for being part of this historic moment with us and Dr. Brown.
Thanks, everybody. See you next time.
Have a great day.
Thank you.